Nervous system diseases, toxoplasmosis, African sleeping sickness, and Neisseria fowleri by Olivia McNeil. Toxoplasmosis is caused by the protozoan Toxoplasma gondii. Toxoplasmosis is found in water, feces, meat, and can even cross the placenta in its congenital tachyozoid form. Humans can contract toxoplasma by eating contaminated meat, such as lamb, beef, and pork, or by drinking water that contains sporozoites, or even from cleaning a litter box filled with infested cat feces. The fact that cat feces is infectious is the reason why pregnant women are warned not to clean litter boxes, as potential infections could spread to the fetus. The human is the intermediate host of the protozoan. The oocyte is a sexual form of the toxoplasma, and it is this form that is ingested by a human. As previously mentioned, this could be from contaminated meat, water, or by handling contaminated cat feces. Next, the oocyte sporozoites are released in the small intestine. This action is triggered by the oocytes coming in contact with the digestive enzymes in the small intestine. Now that the sporozoites are in the intestines, they penetrate the intestinal wall. Doing so triggers the macrophages to phagocyze the sporozoites, and the sporozoites become tachyzoids. These tachyzoids then take the extraintestinal path and replicate rapidly inside of the macrophage. Eventually, the macrophage becomes overwhelmed and bursts, releasing all the newly formed tachyzoids. Cats are Toxoplasma's definitive host. Cats can become infected with Toxoplasma in 3 ways. They can become infected with an oocyte by eating infected feces, or eating infected prey, or become infected with a bradiozoite by eating human food that is infected by humans. If a cat ingests an oocyte, it will go through the digestive system and exit in their feces to become a haploid sporozoite in the soil. If the ingested form is a bradiozoite, 2 things could occur. The cyst wall could become partially digested in the stomach and then finish digesting in the small intestine, leading to epithelial cells becoming infected and merozoites forming, which will multiply in the intestinal cells until the cells burst and release them in the lumen of the small intestine. Or, the merozoites could turn into gametocytes, fuse and make an oocyte, which will exit in the cat's feces and sporulate in the soil, forming haploid sporozoites. The tachyzoid has a membrane-bound vacuole that contains its meconiums and rhoptries. As the tachyzoid is multiplying, it is also releasing cytosine protease, as well as parasitic-specific serine. In combination with the MYR1 protein, these complexes aid the tachyzoid in its ability to prevent lysosome binding, to disfigure the macrophage's cell membrane, leading to the macrophage's eventual release on the newly multiplied tachyzoids. Once the tachyzoids are taken up by other cells, like neutrophils, other tissue cells, and neuronal cells, they begin to differentiate into the sexual stage of bradiozoites. The bradiozoids can then replicate by endogeny, where 2 daughter cells will sexually reproduce in the mother cell before destroying it, or endoplylogeny, which is a process of replication by budding. Once the replication has occurred, the cells become cysts that can be dormant in locations like the brain, kidney, heart, liver, or for the lifetime of the host. If toxoplasmosis is contracted congenitally, there is quite an array of symptoms. In very severe cases, stillbornness can occur. The symptoms will be like hydrocephalitis, hepatosplenomegaly, liver failure, and convulsions, which can all occur. However, it is only true for about 5% of cases. Lesions in the central nervous system are also quite common. However, they can turn into necrotic calcifications, especially if the fetus is infected in the first trimester. Chororetinitis is similar to that, but occurs within the eye, as the retina inflammation leads to necrosis and a pigmented layer forms. That layer can then do further damage to the eye as it becomes granulated and spreads to the vitreous humor, potentially causing blindness. Infection in the second trimester can lead to learning defects and delayed symptoms, such as growth delays, learning disabilities, and hearing loss. Like most infections and diseases, immunocompromised populations are at a much higher risk for severe symptoms from toxoplasmosis. Patients with HIV in particular are at great risk for contraction with and the resurgence of toxoplasmosis. Those with latent infections experience resurgence at such high rates because of the downregulation of interleukin-12 CD4, and CD8 that HIV induces, which would normally prevent interferon gamma inhibition of the toxoplasma replication, which gives toxoplasmosis free rein to replicate unchecked. It is common for HIV patients with toxoplasmosis to experience encephalitis, which is typically accompanied by poor coordination, muscle weakness, seizures, and confusion. So it is not surprising to hear that toxoplasmosis is the leading cause of central nervous system disease in the HIV population. Immunocompromised patients are also at high risk for ring-shaped lesions in the brain and continuous symptoms like papular rashes and interstitial pneumonitis in the lungs, which is the second most common location for resurgence. It is also common for transplant patients to experience resurgence, which typically manifests as endocarditis. The prognosis and symptoms for an immunocompetent person look much different than that of an immunocompromised person. 80% of immunocompetent people with toxoplasmosis are asymptomatic. However, there can be minor symptoms like the inflammation of the liver, spleen, or low-grade fever. Immunocompetent people also may experience swollen lymph nodes. The cervical lymph nodes are especially prone to this. There can be cases of more severe symptoms like encephalitis and myocarditis, which are rare but could pose a significant threat to the patient's life. Diagnosing toxoplasmosis can happen in a few ways. In a patient with HIV, a clinician will typically look for the triad of symptoms, which is having a compatible clinical syndrome, a positive toxoplasmic IgG, and typically brain imaging. However, in an immunocompetent person, toxoplasma is diagnosed with PCR using samples of amniotic fluid, cerebrospinal fluid, or ocular fluid. Serologic methods can also be used, as high levels of IgM would be typical in the first 5 days to 2 weeks after infection, but IgM can also be evaluated in congenital cases. IgG, however, is detectable 2 to 3 weeks after infection, during which time high levels can be indicative of an acute toxoplasmosis infection. Treatment for toxoplasmosis is not a one-size-fits-all situation. If you are immunocompetent, you probably have no symptoms, and therefore treatment is not given. If you are immunocompromised, antibiotic combination drugs are given. The first combination of choice is pyrimethamine and sulfadiazidine. But if there is a sulfa drug allergy, then atovaquone or azithromycin are substituted for sulfadiazidine. Pyrimethamine is an antiparasitic drug that inhibits the folic acid production, while sulfadiazine works by inhibiting dihydroporate. Atovaquone, on the other hand, works by inhibiting the electron transport and is common in the treatment of malaria. Azithromycin inhibits protein synthesis by binding to 23S subunits. Treatment for pregnant women is a bit different, as the medications cannot impair fetus development. In such cases, spiromycin is a preferred medication. This medication functions by inhibiting the protein synthesis by binding to the 50S subunit, and it does not cross the placental barrier, so it poses no threat to the fetus. Toxoplasmosis is most common in places with high humidity, lots of heat, and low altitude. In the US, it is estimated that 11% of the population over the years of 6 years old have had toxoplasmosis. Globally, the estimate jumps to 60%. It is common to see toxoplasmosis infections in Central America due to the high number of stray cats, while it is common to see a high number of infections in France due to the meat-eating practices. A case of this is where a 33-year-old HIV patient was admitted to the hospital with complaints of sustained fever, weight loss, headaches, and difficulty breathing for 2 days. His chest CT showed thickening of his bronchioles, while his abdominal CT showed that his spleen was inflamed. His blood tests were positive for Toxoplasma gondii IgM, but not IgG, which could not confirm it. The patient's continued breathing difficulties and low O2 stats suggested that there was an infection with pneumocystis jirovecii, so he was given sulfametholone, triprimethylproxolone, in addition to his already prescribed ATR medication for his HIV. This action, however, did nothing to combat his fever or respiratory issues, so bone marrow biopsies were attempted twice, but clinicians were not able to get a sample either time. Plasma analysis was then done, and it was showed the presence of Toxoplasma gondii. From there, the patient was given human immunoglobulin, SMZ-TMP, and clindamycin, as well as methylprednisolone, and his ATR medication regime was changed to lopinavir/ritonavir and dolutegravir sodium. The improvement seen from this was significant as the patient's fever and respiratory issues subsided within a week, and within 6 weeks, his chest CT no longer showed thickening or any abnormalities, and his Toxoplasma gondii IgM and IgG levels were drastically higher. African sleeping sickness is a disease caused by 2 types of Trypanosoma brucei, Trypanosoma brucei gambiense and Trypanosoma brucei rodensi. Trypanosoma brucei gambiense is found in the western parts of Africa, while Trypanosoma brucei rodensi is found in the eastern parts of the continent. Both strains of Trypanosoma brucei are flagellar protozoans with a primitive mitochondria called a kinetoplast. Both strains are known to live in mammalian blood. African sleeping sickness is mainly a vector-borne disease being carried by the tsetse fly. However, contraction can occur after eating infected meat as well as congenitally. The tsetse fly is the vector for an African sleeping sickness. The trypanosome's life cycle in the fly is the same for Trypanosoma brucei rodensi as well as Trypanosoma brucei gambiense. Both begin when the fly bites an infected animal. This could be a human or a pig for Trypanosoma brucei gambiense, or a human and a cow in Trypanosoma brucei rodensia. Upon biting the infected intermediate host, the fly obtains a trypanosome with a partially active citric acid cycle. The trypanosome moves to the midgut next, where it reproduces mitotically and becomes a procyclic trypomastogote. This division in the midgut continues for 10 days, and the copies made now have a fully functional citric acid cycle and fully functional chromosome systems. The procyclic trypomastogotes then move up to the salivary glands. Here, they become epimastogotes. The division of the epimastogotes in the salivary glands produce metacyclic trypanosomes, which are infectious. The tsetse fly can now bite and infect other species. When it does so, the saliva gets into the skin of the host, and it injects 40,000 metacyclic trypanosomes each and every time. As previously mentioned, the reservoir species for Trypanosoma brucei are humans and pigs for the Trypanosoma brucei gambiense, and humans and cows for the Trypanosoma brucei rodensi. The cycle begins the same in humans for both Trypanosoma brucei rodensi and Trypanosoma brucei gambiense. A person is bit by the tsetse fly, which allows the metacyclic trypanosomes to get into the wound. Next, the trypanosomes replicate via binary fission at the bite site. This results in a buildup of waste products and necrosis of the skin at the site, forming a soft chancre. From here, the trypomastogotes of the Trypanosoma brucei gambiense enter the blood, forming a trypomastogote. The trypomastogote will then replicate and begins to use the body's glucose stores as the trypomastogotes are aerobic. Now, the trypanosomes migrate to the central nervous system, where they reside extracellularly. However, the Trypanosoma brucei rodensia trypomastogotes enter the lymph, and they begin to replicate. They then move on to the bloodstream, where they replicate even more. Trypanosoma brucei is a very tricky protozoan. Its efficiency comes from its ability to survive with high interferon gamma presence and its affinity for avoiding complement-mediated destruction. Trypanosomes have VSGs, or variant surface glycoprotein antigens, which mammalian immune systems make antibodies against. However, each time the host cells make antibodies against the trypanosomes create another variant of their VSGs. In fact, they can create around 1,000 variants. This process ensues because of the triggering of IgM, which is what recognizes the VSGs and creates a complex against it. However, trypanosomes use TBKLFC1, which allows them to lower the amount of cholesterol, making the plasma membrane more permeable, so that the IgM VSG complexes can go to the flagellar pocket for degradation. It is also important to note that the trypanosomes can reduce the amount of tumor necrosis factor that the macrophages produce. This TNF is what would typically cause an inflammatory response, but the trypanosome is able to stop it with adenylate cyclase. So when the macrophage phagocizes the trypanosomes, that are expressing the adenocyclase, the trypanosome is then triggered to make adenosine monophosphate, which forces the macrophage to release a kinase A and limits the amount of inflammation produced by its presence. The trypanosome also evades the DNA netting, or the DNA shedding, that the neutrophils induce. To do so, the trypanosome uses its flagella and Tdat DNA's mediated disruption of the extracellular DNA traps. In addition to evading destruction in the host cells, the trypanosomes can deplete the host system of glucose and create a buildup of waste products, which is another side effect of their aerobic nature. The symptoms of Trypanosome brucei and Trypanosome brucei gambiens are pretty similar for both. Both will show up as asymptomatic in native animals, but pathogenic to humans and non-native animals. In the case of both types of Trypanosoma brucei, people will experience Winterbottom sign, which is the noticeable swelling of the cervical lymph nodes, as well as the initial chancre at the bite wound, which heals over. The two stages of infection, a hemolytic stage and a central nervous stage, are also present in both. The hemolytic stage is marked by enlarged lymph nodes, malaise, joint pain, fever, and hepatosplenomegaly, while the central nervous stage encompasses symptoms like focal seizures, depression, stiff neck, headache, tremors, coma, and eventually death, which occurs typically from sepsis or pneumonia. Trypanosoma brucei gambiens may not have the central nervous system involvement for years after infection, and its hemolytic stage can last for 3 years. It has a pretty long incubation period as well, which lasts from weeks to months. Trypanosoma brucei has an incubation period of 2 to 3 weeks, and its hemolytic stage only lasts for a week, while the central nervous stage typically occurs 3 to 4 weeks after symptoms begin. Infection with the Trypanosoma brucei in the central nervous stage also involve acquired anemia, which is not a symptom of Trypanosoma brucei gambiense. Diagnosing Trypanosoma brucei can be done in a few ways. Analyzing skin samples from the edge of the chancre can be an effective way of detection, as well as analyzing cerebrospinal fluid. Blood can be analyzed for the diagnosis of both as well, and typically involves the usage of Giesma-Wright staining. When diagnosing a person with Trypanosoma brucei gambiense, in particular, serology is also a helpful tool. Trypanosoma brucei can be detected in the early stages in a person's blood, so doing a smear early in the infection stage would be very beneficial. Treatment options for infection with Trypanosoma brucei gambiense or Trypanosoma brucei are pretty slim. If you are in the early stages of infection with Trypanosoma brucei gambiense, then the only viable options are Suramin and pentamidine, which is given intravenously or intramuscularly. Both of these medications have serious side effects. Pentamidine works to inhibit protein, DNA, and RNA synthesis, while Suramin inhibits enzymes involved in cellular respiration. This medication is only given in the early stages because it does not cross the blood-brain barrier, making it ineffective in the central nervous system. An infection with Trypanosoma brucei in its early stage is treated only with Suramin. Late-stage Trypanosoma brucei infections, however, are treated with Milazepam, which is highly toxic as it is an arsenic derivative. Giving this medication is not one that doctors take lightly, as it results in encephalopathy in 3% of cases. This medication works by inhibiting the production of ATP. Late-stage Trypanosoma brucei gambiense is either treated with eflornithine along with or nitrofurantoin. Eflornithine works by inhibiting amine-based compounds that help with cell division and differentiation, while nitrofurantoin creates reactive metabolites that can have deletion effects in the trypanosome's DNA. Despite the fact that nearly 60 million people are at risk for contracting Trypanosoma brucei, there has not been an outbreak since 1998, when about 40,000 people tested positive for it. The large number of people at risk largely comes from the fact that the tsetse fly has a very large range between the eastern and western parts of Africa. Despite how common travel is nowadays, Uganda is the only country where both types of Trypanosoma brucei are found. However, it does not report the most cases. The Democratic Republic of Congo reported about 615 of the confirmed cases within the last 5 years. Thankfully, however, since 2022, there have only been around 1,000 cases reported, which is quite a drop from the last outbreak. There was a case where a Chinese woman and her husband went on a vacation to the Serengeti, where she was bitten by what the guide confirmed to be a tsetse fly. Before going on this vacation, the couple were given malaria prophylactics and given advice on the mosquitoes and how to combat them. So, when she came down with a fever, fatigue, and dizziness, she was to the hospital. There, she was given broad-spectrum antibiotics, but they did nothing to relieve her symptoms or break her fever. At that point, the woman had no rash or swollen lymph nodes, but she did have a small red chancre on her ankle. A few days later, she had a fever, but now also had a productive cough, headache, and was jaundiced. So she was moved to the infectious disease wing and was given further testing, which showed abnormal liver activity, low potassium, and low platelets in her blood. A shadow strip was also shown in her lungs in a chest CT. At this point, the doctor believed her to have malaria, so they sent her blood out to the CDC so that they may confirm the presence of Plasmodium. However, the CDC found no signs of malaria on the slides, nor was the antigen test positive for malaria, but they did see a few trypanosomes. So they did more analysis into the thick and thin smears that were Giesma-stained blood smears. And their analysis showed that there was a high number of trypanosomes, which confirmed her diagnosis for Trypanosoma brucei rodensi. The woman was given pentamine and suramine, and she made a full recovery within a month. Naegleria fowleri is a free-living amoeba that is found in fresh water with temperatures above 37 degrees Celsius. The amoeba is thermophilic and is the cause of primary amoeba meningoencephalitis, or PAM. People often get this from partaking in what we all consider regular activities, like using a neti pot with tap water, swimming in a lake or pond, or religious ablution. N. fowleri begins as a free-living water amoeba cyst, which converts into a trophozoite and then replicates via promitosis and leaves its nuclear membrane intact. After replication, those trophozoites become flagelled forms, and some remain this way, but others revert back to the trophozoite form. The trophozoite form is the form that is infectious to humans. These trophozoites, and sometimes flagelled forms, enter the nasal cavity of a person and travel along the olfactory nerve to the brain. Once the trophozoite enters the nasal cavity, it perforates the cribriform plate. It then travels along the olfactory nerves and brain base. However, it is theorized that before going through the olfactory tissue, it becomes a flagelled form. After traveling along the base of the brain, it enters the brain cortex, where it has a 15-day incubation period. The symptoms for PAM are often mistaken for other diseases, as they mirror so many others. If a person is infected with Naegleria fowleri, they will often present with symptoms like fever, nausea, frontal headaches, confusion, and swelling in the meninges. Shortly after these symptoms begin, death usually follows. The diagnostic methods for infection with Naegleria fowleri are unfortunately slim. Oftentimes, clinicians do not consider N. fowleri as the cause of a person's symptoms and therefore do not follow the required procedures right away. Presumptive diagnostics of this amoeba can happen by collecting information about the patient's recent activities, like swimming in a lake known to harbor N. fowleri. However, definitive diagnoses come from the analysis of cerebrospinal fluid for trophozoites, which is done by a spinal tap, or the biopsy of brain tissue in an attempt to find lesions created by the amoeba burrowing into the brain. However, most diagnoses are sadly given postmortem, as the fatality rate with infection of this amoeba is over 97%. The biggest factor in treating N. fowleri is early detection and treatment. Many medications are given in the fight against N. fowleri, though the most important would be amphotericin B. This medication is an antifungal that works by targeting sterol, an important component in membrane permeability. Rifampicin is an antibiotic that inhibits RNA synthesis, while fluconazole is another antifungal that is commonly given in cases of meningitis, which works by inhibiting fungal cytochrome P450. Miltefosine is a medication commonly given in parasitic infections. It inhibits cytochrome C oxidase to promote cellular apoptosis. Despite N. fowleri being an amoeba, all of these drugs that are typically used for other classes of microorganisms are commonly used, which truly speaks to the resilient nature of N. fowleri and the severity of an infection with it. Another treatment that has been experimented on is cold cap therapy. It is quite similar to the cold cap therapy given to chemo patients, except it isn't to prevent hair loss. It is thought that by cooling the head, the swelling of the brain will go down, and the trophozoites may stop moving, as they are, after all, thermophilic species. Cerebrospinal fluid drains are also a common factor in the treatment of N. fowleri infections, as a means of reducing the amount of meningoencephalitis. Thankfully, N. fowleri is not a very common infection. However, it is found in the US, Southeast Asia, Central America, Australia, and the Middle East. The Middle East is an area where there have not been many cases. Actually, I believe there's only one, but the higher usage of religious ablution puts people there at higher risk. The US actually has the most cases, with most of them occurring in Florida. However, as climate change worsens, we are beginning to see more cases in northern states like Colorado. As previously mentioned, the mortality rate for PAM is almost 100%, making the 7 survivors rare. However, most of the survivors now suffer from debilitating side effects, like being in a vegetative state. In 2018, there were 381 cases reported, and hopefully that number diminishes each year as we continue to research into early detection methods and public awareness. There's a tragic but interesting case of this, of an N. fowleri infection in a 4-year-old boy from Mississippi in July. One day, he began having diarrhea, which had escalated to a fever, vomiting, and headache and staring spells by the next day, so he was admitted to the hospital. There, he continued to have headaches, and his blood showed to have high levels of white blood cells, so he was given vancomycin and ceftriaxone. Later, he was given a CT scan, which looked normal, but his lumbar puncture was cloudy instead of clear, and there were high levels of protein in white blood cells, so they added piperacillin tazobactam and aclovir to his regime. The following day, the boy was irritable and his level of consciousness changed frequently, so he began having focal seizures. But this time the CT scan once again showed nothing, so he began taking levetiracetam for his seizures. Later, he had to be intubated and an intraventricular drain was placed. He continued to have seizures, and his MRI now showed edema in his frontal lobe. On the 30th, he was given a frontal craniectomy to relieve some of the pressure in his skull. However, during the procedure, hemorrhaging was seen on his dura, and the brain swole out of the dural opening. To combat that, cerebrospinal fluid drains were placed, and he was placed in a medically induced coma. On the 1st of August, he was pronounced brain dead. But where did this come from? On the 18th of July, the boy had been visiting his grandparents in Louisiana, where he played on a water slide in the neighbor's yard. The water supply for the slide was provided by 2 hoses connecting to a neighbor's spigot. Officials in the Department of Health and Human Services took water and soil samples from the grandparents' house as well as the neighbor's house and sent them to the CDC, where a startling discovery was made. The water supply used for the slide had tested positive for Negleri fowleri. Sources cited.